Yes.
Um, well, good morning and welcome back, everybody. We are the Audio-Vestibular Medicine case discussion group. Oh my goodness. All right, here we go. There we go. All right, so we are presenting monthly interesting cases in audio-vestibular medicine. I'm one of the three hosts here, Jerry Gianoli. I'm located in Covington, Louisiana, which is just outside of New Orleans. We also have with us the my two esteemed colleagues, Mohamed Hamid, who is in the Cleveland, Ohio area, and Eugen Ionescu, who is in Lyon, France, which I recently learned was the origination of Lyonnaise potatoes. Is that true, Eugene?
Linus potatoes. Yes, I
Yeah,
think that it's a kind of particular recipe here.
yeah. In any event, but everybody's encouraged to join. The information discussed is meant solely for educational purposes and not intended as medical device advice for any individual. For individual medical advice, please seek the counsel of your own physician. While these conferences are geared toward medical professions, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. And we have archived our discussions on our website, which is at AVMC, AVM Case Discussions. And today I'm going to present a case on dizziness after stapedotomy. This patient was a 49-year-old gentleman who came to see me 3 months after a stapedotomy with the chief complaint of dizziness. And the backstory is he had, for many years, slowly progressive bilateral hearing loss that was diagnosed as otosclerosis. 12 years before presentation, he underwent a left stapes surgery with a very successful outcome. 3 months before presentation, he underwent an uneventful right stapes surgery. However, 36 hours after that surgery, he developed severe vertigo, vomiting, and right-sided hearing loss. So I think right now is a good time just to open up the discussion about what is the differential diagnosis of someone who has dizziness after stapes surgery, and what would you do about it? Mohammed, you want to start off the discussion?
Sure. Well, the first thing that one would think of is if the prosthesis has kind of gone too far, infection. Uh, those would be the two things that would come to mind, actually.
Eugene, you got some other thoughts?
No, to this point, I agreed that we must check about if the prosthesis is in place. However, I would say that he had a very important hearing loss. Um, should imagine that is not only an eventual post-surgery fistula.
Yeah, I think those are great ideas. I think, this is a little bit more narrow than just dizziness after a stapedectomy because he's also got significant hearing loss, which kind of narrows things down.
The
Probably in my mind, the most common reason for dizziness after stapes surgery is just a little bit of inflammation, swelling from the surgery that generally is
Sure.
mild and kind of goes away. BPPV can be seen after stapes
Yeah.
surgery, does not present with hearing loss, obviously.
Yeah. Yeah.
Um, but perilymph fistula is certainly one consideration. Although I'll tell you the scenario with this particular gentleman, he developed this after waking up from a nap, which doesn't sound typical for a perilymph fistula. Um,
What happened with the left ear 12 years ago? No, no problem was
Yeah,
successful.
no, had a good result, no
Okay.
complications,
All right.
everything went fine with that. And that's why he wanted to get the other side done. So what do we do next? And I'll just kind of list out for you what happened. His nausea and vomiting and vertigo were so severe that he went to the ER, where he had a white count of 18,000
Ah,
at that time.
infection.
And they did a CT scan that was read out as indicative of otitis media and otitis externa with the prostheses in position bilaterally.
Yeah.
Although I will say, a CT scan in someone who had recent stapes surgery, the post-op changes are going to be a little hard to distinguish between what would look like with an otitis media and otitis externa.
Yeah.
Um, he was diagnosed with acute labyrinthitis and was admitted for IV antibiotics and IV steroid. And within the next day or so, his vertigo was much better. He was discharged the next day on oral augmentin and prednisone. He was seen the following week by the surgeon who did an audiogram and showed a profound hearing loss in that right ear. And the following day brought him in for middle ear exploration. And I think part of the thought process was, could this be a reparative granuloma, which is another thing that can be seen after stapes surgery, although it's typically not 36 hours later. It's usually more like a week later that you typically see that. But during the surgical exploration, the surgeon found inflammation, white pus globules, and decided to change out the prosthesis and sealed the oval window with fascia. The previous procedure was just a blood seal that they used. They sent cultures which did not grow anything out. Afterwards, there was no change in hearing, and he was sent for physical therapy, for vestibular rehab therapy, and that did not seem to make too much of a difference for him, and hence he presented to me at about 3 months after his surgery. And again, his complaint was persistent dizziness that was not improving. And I always ask for triggers, what makes your dizziness worse? And the only thing he came across was head movement and strenuous type activities, lifting, exercise, bowel movements would provoke his dizziness. He also noted he had intermittent diplopia at times. And during his exam, his gait was okay, and his Romberg was normal. But when we did the Fukuda stepping test, he fell to the right side. He was very off balance when he would close his eyes. And I have his IR video exam. Well, he had left beating spontaneous nystagmus
Mhm.
on his IR video exam. And I have for you here, this is his head shake test, which I thought was kind of interesting. And you'll see at the beginning is me shaking his head, but then you'll see where I stop and what happens afterwards. So we're shaking his head, and then we stop here. And you can see he's got a pretty nice left beam nystagmus, but then he gets strabismus, which I think explains some of the double vision he talks about.
Sure.
Eugene, you're muted there. Eugene?
Yes, yes, I see. I saw it. I think effectively that this strabismus might explain the diplopia.
Yeah.
Since
I wanted to ask a question to you guys because I periodically have patients that talk about this, and I will see this at times. And I'm wondering, how often do you guys see patients that get nystagmus that turn into strabismus?
not very much for me.
No, yeah, not very much. It's probably has the diplopia, maybe a medial rectus palsy or something like that.
Well, the way I kind of explained it to myself is this is probably someone who had an ocular motor weakness in his deep dark past, and that when he gets the strabismus, it kind of like destabilizes compensatory mechanisms, and he goes whoop. That's my little explanation for it.
Jerry, do you have the pre-op audiogram?
I don't have it in the slideshow, but he had
Okay.
a big conductive hearing loss, and the bone scores were symmetric.
Okay. And post-operatively in the OR after the patient wake up, didn't have any issues at all.
No, and his hearing was improved after the
Really?
surgery. Yeah, the
Okay.
patient
Oh,
Wow.
okay.
noted the hearing was improved right after the surgery, but by 36 hours, it had gone down. Yeah.
And he had not a shock at the head, not even a minimal traumatism.
No, no. And like I
Okay,
said, when it was like the next day, he took a nap and then woke up with the horrible vertigo that just progressed over several
okay.
hours and went up in the ER.
And this is
Not
when the patient realized that his hearing also has gone.
Correct. Correct.
Okay.
All right, and this is the audiogram we got at the 3 month period. And you can see the left ear, he's got some sensory neural component, little, tiny low
Conductive.
frequency gap,
uh,
but functional hearing on that left side. His vestibular evaluation, I don't think would be a real surprise to most folks. We could not measure much in the way of any residual vestibular function on that right side. He had, for all intents and purposes, 100% canal paresis on caloric testing. VHIT showed the right side down. CVEMP was absent. OVEMP was absent in the ear. Fistula test and Valsalva test were negative. But interestingly, when we did the Tulios test in the right ear, he was symptomatic from that. But it didn't change his spontaneous nystagmus. The left-sided tests were all normal, except there was no response on the OVEMP. And
What was the left caloric like? The chair test is showing obviously bilateral reduced gain. We cannot look at the phase or the symmetry with that. But yes, it's a reduced vestibular function. So his left ear, the healthy ear,
yeah,
does he
the
have?
health, the yeah, Mo, the calorics on the healthy ear were quite good. Uh,
Oh, okay. So
yeah,
it's a
and
unilateral yes.
yeah,
Okay.
and the V hit for the left ear was good. The C vent for the left ear was normal. Could not get an O vent though, and
Yeah.
I'm not 100% sure why we did not get an O vent on that side. But that was the only abnormality I could find on the left side. So,
and excuse me, Gerard, on the you told us that there was a right Tulio test, but you perform with what stimulation? What do you use as the stimuli?
so it's 500 hertz at 105 decibels, and we do a pulse tone, and we do it for
Okay,
I think about
but
10
the
seconds.
10 seconds,
Yeah,
5 kilohertz. You know,
500 hertz. So low
500.
frequency.
Okay,
Yeah.
500 hertz. Okay, and the characteristics of this left nystagmus didn't change.
No, it did not
Okay,
change. Not, at least not to
but
my
he felt the dizziness. He
right. It
was
felt
dizzy.
like it made things
I
worse.
mean,
Yeah. Yeah. And so at this point, I'll throw out to you guys, why is he not getting better? What's your differential diagnosis and what should we do next?
You go first this time, Eugene.
Can I ask one thing? Can you repeat
thank
that
you.
goggle thing again one more time?
What's that, Bullet?
Can you do that goggle thing the one more
Sure.
time? Like so that's okay.
Yes, it's a
And
left.
so the end here, that's, kind of getting to what his spontaneous looked like. It wasn't a really bad spontaneous, but it was obvious on the goggle exam.
Yeah, I mean
Okay,
it's a definite left beating
and
post head shake nystagmus.
it was accelerated by the head shaking test.
Yes, sir. Yes, sir.
Definitively. Okay. So
So,
for me, I just think maybe a labyrinthitis because auditive and vestibular impairment is very important. And I don't know, different diagnoses dizziness with the Tullio in relation with an eventual Tullio phenomenon. Why not? But I don't know. I think that the most important thing to do is to try to take an CT scan.
Okay. And
Um,
no?
so I think, well, we have a right total vestibular loss. And now you said it's been 3 months. Patient should have compensated by then. So there is an ongoing something in that right ear.
That's
Maybe
kind of the way I looked at it. I thought to myself, he's got a history that is very strongly aligned with a suppurative labyrinthitis and just basically wiping out that ear. But the fact that he's not compensating suggests there's something still fluctuating. And
Yes.
in my mind, the fact that he had a little bit of worsening with the Tullio's test suggests that maybe there's still a little bit in that right ear
something.
that's
Yeah.
kind of provoking things. And so I was with Eugene. I thought the next thing I was interested in was what does a CAT scan look like? And that's what I have next for you guys, and what I did was I got the old CAT scan that was done right when he was in the ER, which was post-op day number 2, and put it next to the recent one and compare the two. So the one on your left side is post-op day 2. The one on your right side is 3 months post-op. And it's quite striking. This is a axial slice through the
Yeah.
superior semicircular canal. It looks pretty normal here. But if you look at the one that's 3 months out, the bone is
Eccentric.
ratty
Yeah.
and kind of dissolving, and it looks like we've got a frank dehiscence of the superior canal on the 3 month scan. So as we move further down the inner ear,
Mhm.
the other thing that's striking was the posterior semicircular canal. Look how dilated it is and ratty it is. It's just it's like expanding. Plus, you got all this soft tissue stuff here that wasn't there before. And let's go further down the inner ear. And these aren't exactly the same, but again, this I wanted to show. Here's the posterior canal, and compare that to the otic capsule bone over here. It's like it's almost gone
Yeah.
compared to what we got here at 2 days after surgery. This is a little bit further down, and again, here's your posterior canal, the inferior side of it, and it's so dilated that it's almost unrecognizable. And here's some of that stuff in the middle ear, and as
Mhm.
well as the middle ear over here. Here's the prosthesis. Um, and then this is a little bit further down. Again, ear canal filled with junk, stuff in the middle ear. And again, the same on the 3 months post-op. And
Do, do
then
you, do you have the parasagittal views?
I do, and actually I have a partial view I'm going to show y'all in a little bit. That's kind of
Okay.
interesting.
Yeah.
So at this point, in my mind, it's like I want to see, because this looks like the inner ear is just dissolving. There's still an active process going on to where I wanted an MRI scan done. And so the MRI, we did an MRI scan which showed labyrinthine inflammation, dural enhancement, and the radiologist was concerned that there was a sigmoid sinus thrombosis next to this process. So we got an MRV done that was normal. Um, so at this point, any thoughts on what we should do?
What is his that may be relevant or irrelevant? White blood cell, did the inflammation subsided?
I'm sorry, say again?
The his white blood cells were 18,000, I think.
Oh yeah, no, they had
Did
come down. Yes, sir.
just come
Yeah,
down and
yeah.
no pain, nothing.
I think there was some mild discomfort
Yeah.
there, but nothing really. Clinically, this guy did not look toxic. He did not look like somebody who's on the verge of getting meningitis.
Okay.
His main issue was just he was dizzy. Now he was concerned about not being able to hear, but he said the dizziness, was just keeping him from functioning. And like I said, when he had low light situations or eyes closed, this guy would just fall over.
Yeah. Um, okay. I think it is whatever residual function in that right ear, vestibular function, needs to be quieted down.
Yeah. I think also that that is an uh, local processes of infectious processes on the temporal bone, on the petrosal bone, namely on the top of the pyramid. And I think that should imagine, and there is some signs of demineralization, probably in relation with the infection. So maybe there are some cases with anaerobics bacteria. I don't know if they try to obtain the results and eventually in relation with negative stain negative bacteria. But I think that this patient should be um, operated, and it's okay that you perform also an angio MRI, because effectively when you have a diplopia, should eliminate an thrombophlebitis, and there is a risk of cerebral sepsis, including meningitis. So I think that even that the clinical picture is not very typical, but the CT scan it's compulsory in this direction, I think.
Yeah, I had the same concerns. I mean, especially seeing the dural enhancement and this process, which went from no bone loss to dissolving the inner ear in 3 months. The concern was it was again, I'm worried about meningitis and things like that. So I recommended an urgent labyrinthectomy.
Yeah.
The other another thought that crossed my mind, because I did not see the prior CAT scan until later. So when I first saw him, I just saw the CAT scan showing all the bone dissolution. And I started wondering, well, wait a minute, was this something that was going on before he had the surgery? Does he have some kind of neoplastic process going on there as well? So I wanted to make sure. That's why I got the old CAT scan to see, was it really a normal inner ear before, and to compare the two. So when I did the labyrinthectomy, the lateral mastoid was normal, but as I got medially, I got into a lot of granulation, inflammatory tissue, and I have done a ton of labyrinthectomies in my career, and this is probably the second most difficult labyrinthectomy I've ever done. And it's mainly because the bone architecture, a lot of the landmarks we use was just gone. The posterior canal bone, I couldn't even really find it, to be honest with you. And then once I got into the inner ear, as you guys know, the inner ear contents are just basically just endolymph, perilymph, and this really thin, membranous labyrinth that just scoops out real easy. That is not what I found. The membranous labyrinth was very fibrous, very thick, inflamed, very difficult to remove. It was like actually kind of invading into the bone. And then there was an area that was at the very end where the utricle and saccular receptors are, where I went to scoop it out. It just would not come out, and I had to basically pull it, and it was adherent to the dura, and I wound up getting a CSF leak from it, which I had to plug up with a muscle plug. But I sent off all the stuff for biopsy. It just came benign inflammatory and tissue and fibrosis, and the cultures came back Pseudomonas aeruginosa.
Huh.
which kind of explains, it's almost like it was a chronic, osteomyelitis, if you would. And here's here's on the left. I was just kind of showing this is the area where I think the bone had kind of dissolved between IAC and vestibule. I think when I pulled that last little bit, I got the IAC dura. And this is a partial view showing the posterior semicircular canal. As you can see, there's like orphaned pieces of bone here and there, and the lumen of the posterior canal is severely dilated. Let's see what else we got here. So I looked up because I seem to remember that a couple of reports on cases where someone had labyrinthitis and the bone had dissolved. And there's about a dozen cases in the literature reported on something called labyrinthine sequestrum. And it's a consequence of labyrinthitis felt to be bacterial in most cases, where there is sort of centrifugal destruction of the inner ear. And it's been seen typically either after bad, chronic otitis media and also after surgical interventions. There's 3 cases reported after cochlear implantation, a couple of cases after stapes surgery. I believe there's 1 or 2 after other types of surgical intervention into the inner ear. And this is just the only histology I could find out was in a paper by Bali et al. And it shows the normal bone of the inner ear compared to all the dissolution that you're seeing in this labyrinthine sequestrum that it's been termed. Another term I believe they use for it is osteolytic labyrinthitis. Um,
What,
so, yes,
what,
sir.
what was his, I mean, never had any illness or sickness before the surgery, the initial surgery, no your surgery. And how did he get the Pseudomonas?
Presumably it's was from contamination during the surgery.
Okay. It's just the course doesn't add up, does it?
In what respect?
And the thing, he didn't have any, again, we don't know if he had any prior infection in the ear before the surgery.
Yeah, it would seem like it's either from an external source. It seems like, with him getting the severe labyrinthitis 36 hours, it implicates the surgery. The other thing I wonder about is when he was seen for labyrinthitis, he only got 24 hours of IV antibiotics and then was placed on oral antibiotics, which I think is really inadequate for a suppurative labyrinthitis. Now, nowadays we see suppurative labyrinthitis so seldom compared to in decades past, but it's sort of tantamount to having a brain abscess or an epidural abscess in that you can't just treat it like it's a little ear infection. These are ones that can turn really ugly on you. And so what we did with this patient is I consulted ID, and he got 4 weeks of intravenous antibiotics directed to the Pseudomonas culture we got, and then was placed on oral antibiotics for 2 weeks after that. And then put him into vestibular rehab. Also got a post-op MRI about a month after the labyrinthectomy, and did not show any extension of disease, just showed some post-op changes and no intracranial sequelae. Also, too, I think is Abby in the conference?
I'm here. It's so cool to see the imaging.
Yeah, so Abby is the patient's vestibular therapist, and I was just curious if you had any comments to make about his recovery so far.
Yeah, absolutely. I am his vestibular therapist post seeing Dr. Gianoli, so not that first round of therapy that he had. And I think primarily the message that I want to convey is that um, he has required more than just your standard vestibular exercises, and I'll explain why. He's an athlete in his background. He was a professional surfer.
Oh,
He's very much he's very much in tune with his performance and wants to see objectively how he improves. Now, something unique about the therapy that I provide is it's virtual. Most of the patients I provide therapy for are more in the 3PD vestibular migraine chronic presentation, but he is obviously more acute. So we've worked a lot not only on VOR and different walking variations and head turn exercises and changes in direction, and also improving his ability to tolerate visual stimulation, like in busy environments. But also, we've been working a lot on his mindset and understanding how to recognize progress through more than just symptom decrease. So, a few things to note. I had him redo a dizziness handicap inventory and also an ABC scale, which measures his confidence with various activities. And his DHI was primarily the same. I've been working with him for about a month. However, his confidence scale went up over 20 points. In addition, he's demonstrated the ability to progress his exercises week to week. So I think he's the type of patient where he lives with himself every day and can't necessarily recognize the small improvements day to day or week over week. But when you zoom out and you show him, okay, this is where we started, even just walking without head movement, you weren't completely comfortable, to now he's walking with head movements every couple of steps. We're doing eyes open, eyes closed, and really challenging him to get him more in that yellow zone and promote recovery, but also making sure he understands when rest is required so he's not overwhelming and accumulating symptoms. He's been part of his therapeutic approach is also getting him back into things that he enjoys, both as a father and just as a human being. So things like mowing the lawn. He didn't mow the lawn for a while. He had this really big community event that I think he does every year, but he was very worried about it this year. So we talked about how can you change your approach so that you can function well and not skip out on these events. So things like maybe more one-on-one conversations instead of group conversations, paying attention to what your background is, like facing a more stable, quiet background versus an area where maybe there's lots of people walking by. And then obviously over time, continuing that exposure so that he's more and more functional in real world environments. Another thing that we have spoken on is he really wants to get back into the ocean, paddling specifically, not surfing, but the ocean is really his happy place. When I spoke to him about triggers in our initial evaluation, he actually didn't mention anything about like bearing down being problematic for him. It was more head movement and then also visual stimulation or repeated movements, such as looking at the ocean. So part of his
so
exercise.
can I
Yeah.
don't mean to interrupt,
No,
but
please.
what was going on with his spontaneous nystagmus during the rehab course? And by the way, the DHI is really a psychological
Mm-hmm.
scale, not
Yep.
a physiologic vestibular scale. So were you able to see any regression in his spontaneous nystagmus? Even that also, Jerry, after your surgery, did the
Yeah,
spontaneous
you know,
nystagmus persist?
yeah, it's interesting. I saw him a week after, and I guess I could have put this on the slideshow, but a week after the labyrinthectomy, and I did another head shake, and he gets some, of the left beating nystagmus, but he didn't get the strabismus
Okay.
afterwards. And I think there was some improvement, even just that first week afterwards. I think Abby, I think one of the things in retrospect, the reason he was probably getting strain-induced dizziness is because we talk about strain-induced dizziness being one of the hallmark signs of labyrinthine dehiscence. Well, this guy had major dehiscences all over the
Yeah.
place. I mean, his whole inner ear was just kind of falling apart. So I think getting rid of that probably got rid of that particular symptom.
To answer your initial question, I have not seen him in person to look at him to do a full infrared goggle assessment. What I do is more function based because I'm virtual. So my approach to him is more activity based and also mindset based, because just like you said, the DHI is more subjective, how this patient is perceiving. So at the next session, I just had him redo these assessments. And the next session, I'm really excited because one, I'll be able to talk to him about that change in confidence level, even though he might not feel it. That's even showing on reassessment. But there's a device, I don't know if any of you have heard of it, called the Vertiginous sensor. It's basically a wearable device like a hearing aid, but I think he'll benefit from it because he wants that objective, real-time feedback. And the device is connected to an app in which it gives him feedback on, okay, how is he moving his head? Is he maintaining the frequency of head turns when he's doing VOR? Things like that. So this is very new technology. It just got approved in the United States. He'll be the first patient that I implement this with. So I'm looking forward to seeing if that positively impacts his experience and allows him to maintain the motivation and see his progress over the course of time, because it also does kind of daily or weekly.
The main concern here is in the course of any vestibular rehab program, if there is any visible vestibular nystagmus during the rehab, whether it is virtual or not virtual, that actually is something that need to be addressed, because the continual fluctuation or continual active one side is going to interfere with any vestibular rehab program. So I guess my question is to Jerry, do you think he still have any irritative source from that ear? Or I hate to also put the question, what about his left ear? His left ear is a post-stapedectomy as well. So we need to kind of look at it from that point of view, or I would.
Yeah, so those are great questions and ones that have gone through my mind as well, Mo, and which leads me to the one last question I have here. When we did the CAT scan on the good side, on the bad side, he's got all these dehiscences and the bone's dissolving.
Okay.
On the good side, he has an asymptomatic superior canal dehiscence.
Oh.
And so, in all of the testing I did with him, all of the questioning, we really did not find any evidence to suggest it was active. But the problem, as you know, is our testing is limited. He could certainly have some minor fluctuations of vestibular function on that good side that's going to screw up his compensation from the right-sided loss. We had a big discussion at the academy meeting in the fall about if you have someone who's got an asymptomatic superior canal dehiscence and they have otosclerosis, should you do a stapedectomy? And I am firmly in the camp of you do not do a stapedectomy on somebody who's got an asymptomatic superior canal dehiscence, and it's mainly because of the concern of basically causing them to have symptoms. But I think also long-term, it increases the risk of the superior canal dehiscence becoming symptomatic down the road. So, the big question I was going to ask you guys is, you've got this guy now, he's got no function on that right side. And I can tell you, I did a really thorough job of getting rid of the sensory epithelium on the right side. So he's basically just got one vestibular ear, his only one hearing ear, and it's on the side he's got a stapedotomy on that side, and he's got an asymptomatic superior canal dehiscence. What sort of precautions or recommendations would you have for him in the future regarding his good ear?
Well, I would like actually to look at his caloric test in the supine and prone position, irrigating the left ear. I think that would give us a little bit more information.
Wait,
And
no, the left ear is the good ear.
I'm sorry?
The left ear is the good ear.
Yes, that's what I mean.
No, but he's got
And
normal calorics without having to do ice water.
well, I mean, that's fine, but normal calorics, the question is, if he has definite post-head shake nystagmus and the right ear vestibular system is out of the equation now. So we need to focus on why is that nystagmus. It could be irritative nystagmus from the left ear. So that's one thing I would do, a prone and supine, and see if there will be any changes.
Well,
And
let me ask you, Mo, I don't quite understand what would be the advantage over routine calorics using ice water prone calorics and in a year that you're already getting,
in
a
the
good
presence,
response.
yeah,
Yeah,
very
what's
good
the
question.
advantage?
Very good question. If he has any residual spontaneous, positional, or post-head shake, I would have to assume that it's coming from the left ear. And if we try to inhibit it and see if the nystagmus would disappear or change, then we're dealing with a, if you want to call it, subclinical fluctuation of the vestibular function on the left side. Because the right side is out of the equation now, would you say?
Oh yeah, no, it's
Okay.
gone. Yeah.
So any spontaneous post-head shake, BPPV, it has to be coming from the left ear. So I would love to examine this patient. That's a very interesting case.
Yes, I may add that in our experience also, we have some cases with patients we have experienced labyrinthine and vestibular impairment, partial or complete, and there was asymptomatic before. And we expected to observe a normal compensation after 3-4 weeks with the physical re-education, physical therapy. But finally, we behind a case like that, which didn't compensate with still a slight nystagmus, we ask ourselves if the problem is not on the good vestibular side, which remains stable, supposed to be stable. And we find sometimes some little problems on the healthy sides, which explain why the compensation, the central compensation, didn't occur. So I think in this case, as Mohamed said, that there might be a problem, a little fluctuation. Maybe even they are not the patient did not have classic symptoms for a third window, um, assimilated third window because it was otosclerosis before. I think maybe there are some slight vestibular fluctuation infraclinically, but which is expressed like an incomplete compensation. This is a point emphasized by Mohamed. I think it's very pertinent, and it's very important, as you know all, that before to work to try to obtain a perfect compensation, post-stroke compensation should stabilize the labyrinthine structures.
And if it happens that this is the case, I probably would go ahead and do a little bit. I would do one injection of gentamicin in that ear.
So, well, let me ask this: Would any of you advocate using like acetazolamide as a treatment for the asymptomatic ear?
Maybe. Maybe
Maybe.
because apparently the superior semicircular canal descends on the on the left. Maybe we had, and this is I will not promote my last article, but our last paper. But why not? We can imagine that this light descent, we can observe maybe an partial spontaneous auto-occlusion of the superior semicircular canal, and in this case, effectively, the brain could vary the pressure of the even in the absence of the clear Tullio phenomenon, and could explain the instability of the left labyrinthine structure. Why not to try, as you told, to avoid every stress that you emphasized in the monography, avoid the micro-traumatism, etc., etc.
So a little bit different question. Okay, so we have a gentleman who has lost his hearing, and I talked to a few fellow neurologists when I was preparing to do labyrinthectomy on this gentleman, and they suggested that I put a spacer in for a potential cochlear implant down the road.
Yeah.
And I did not do that, mainly because I didn't want to leave a foreign body in this ear that's got essentially kind of an osteomyelitis. And knowing that they had, at least 3 cases in the past where cochlear implantation was the cause of this. Any thoughts about, I guess in my mind was, I'm not worried about labyrinthine, ossificans in this case. I'm more worried about just the propagation of the infection. I'm thinking down the road, you can always do a cochlear implant later. And I don't know the spacer is going to be helpful versus a hindrance. Any thoughts about that? Eugene?
I don't have any thoughts about it.
I agree with you. I wouldn't put anything there too. You're absolutely right. It will be a stupid idea. That was the problem with the first case. If he didn't replace the prosthesis, maybe this patient may have not progressed to that level. Absolutely. I wouldn't put a spacer. Definitely we're gonna get something in there. You did the right thing.
Okay. Yeah, I just felt, I was torn because I didn't want him to not be able to hear, and also knowing that he's got a precarious ear on the other side. But at the same time, too, it's, I kind of like, okay, life before hearing is the way I kind of put it. Anyway, so that's pretty much all I have on this case. What's that?
Absolutely, you did the right thing. It will be a very, very wrong idea. It was, I think, like I said, repeating again, but if he didn't maybe replace it with the different things, this patient may be saved.
So, Bulin, any other thoughts about this case? Things that you think?
Well, I do apologize that this is a zoo here, so I have to go in and out a couple times. So, but you did a fantastic job. I mean, this is very interesting. This is beyond that we know about the granulation and everything. This progress into a real new mess. And you're finding with this goggle thing, which you do it with binocular, which is much better than I do because I do uniocular. It's very interesting to see this strabismus. Why is this happening under?
So if those goggles I use, they're from Vestibular first. I got them, they're probably some of the best goggles I think you can get for the price on the market right now, because most of them charge an arm and a leg to get some goggles. So if you're interested,
what company is it? What's the company?
Vestibular first.
Vestibular first.
Yeah.
Vestibular first. Yeah.
Yeah, I've been very happy with those goggles.
Yeah.
Oh, they're
Goggles
great.
is very important in, I think, for the exam, especially dizzy patients. That's so interesting.
I have a different question, Jerry.
Yes, sir.
If we look at his left ear hearing test, would you have done a stapedotomy on this patient?
I would not have done a stapedotomy on him because I would have done a CAT scan beforehand, and seeing the superior canal dehiscence, I would not have done it.
Okay.
And like I said, we had this discussion at the academy meeting in the fall, and there are some that would say, oh, it's not a problem. But in my mind, stapedectomy is an elective procedure, and you only do it under the absolute perfect conditions and with the patient full aware that there's a risk they could go deaf from the ear as well. And last time I checked, hearing aids work pretty darn good. And it may not be as, some of the patients may not be as happy with it because they don't like the cosmetic effect of a hearing aid, but especially in a conductive hearing loss, hearing aids work great, much better than sensory neural loss.
Yeah. Yeah, I just, it's a very interesting case and raises a fair number of questions, and I think we have addressed most of them.
Awesome.
Yes, I think also that in this case, the priority is, if you may, Boland, I'm perfectly on the same position because the priority was here the infection which evaluated, and the risk of the cerebral infection, etc., was here. So after that, the labyrinthitis with this modification. What did you use? You opened the labyrinthine. What was the procedure, the
Uh,
surgical
so,
procedure?
so I did a transmastoid labyrinthectomy, and typically I will approach the horizontal canal first, open it up, and then follow the superior canal around and connect it with the posterior canal, and then just scoop out all of the sensory epithelium, which, like I said,
Okay.
in his case, was just very different. I have had a couple other cases of kind of a fibrous stuff, but nothing like his. His was unique. And I think it's because it was kind of invading into the labyrinthine bone that made it so difficult to remove the membranous labyrinth in his case.
And you have not the liquidospinal leak at
So at the
there's no.
very end, as I was scooping out the utricle and the saccule, it would not come out, and so I took a little cup forceps to pull it out, and it pulled open a little tear in the dura, and I got a spinal fluid leak. So I just plugged it up with a piece of temporalis muscle, and it settled down easily, because it was almost like putting a cork in a bottle, if you would. Um, and it seems like that's worked. I guess he's about 6 weeks out from his labyrinthectomy now.
And
Okay.
when did you see him last, Jerry?
Well, I saw him last a week out, but I've talked to him via televisits a couple of times, and he's continued to progress. And I think I'm bringing him back in about a month to look at him. I got a post-op MRI scan at a month afterwards, and that was the other thing, because this is such a unique case. I don't know, at what point should I do imaging again? And basically I told him, let's do another scan, maybe when we're 3 months out, just to be sure that there's nothing residual going on. Because he was not one that clinically, other than being dizzy, you could tell he had this ongoing infectious process going on. So he kind of scares me in some ways.
Yeah. I think it would be interesting also to see if he still has that left beating nystagmus.
Yeah, I think if he does not get adequate, compensation, it's certainly worthwhile looking at again. And I'm with you. I think if he doesn't, it's probably because there's something going on with his good ear.
Yeah, yeah. A great case today.
Yeah.
Question for you all. From the rehab perspective, is there anything you recommend I do additionally to what I'm doing now?
Well, I think just from a precautionary standpoint, knowing he's got a superior canal, the two big things, and I've told this to him, is one, you want to avoid head trauma, and two, you want to avoid any major pressure altering
Yes.
events.
Mm-hmm. Which
so-
we've talked about, Dr. Gianoli, you and I.
Yeah, heavy straining, anything that would provoke problems with his good ear. Because I think if he gets symptomatic from that superior canal on the left side, I think he's in deep doo-doo. And that's a
Yeah.
medical term. You can quote me on that. But
No, it will.
then nobody's going to want to do any kind of surgical intervention on that side, nor would he would want to. And you can do some medical stuff for it, but it's kind of like you're better off I think, being a little bit more cautious in preventing problems rather than trying to treat it after the fact.
Yeah, I would definitely agree with that. And I'm also wondering about his driving. That sometimes can be an issue. But I know it's hard to address, but it's up to him. He has to be aware that his vestibular function is still not 100% right. And I would add to your comment, Jerry. I think I would be encouraged to do a gentamicin injection in that left ear. I would do it.
I would be hesitant to that for two reasons. One, I'd be worried about causing hearing loss in his only hearing ear, and then the other is if things aren't quite right, you could wind up getting a bilateral vestibular loss, which I think would be just as devastating.
Oh, sure. But in his case, we need to get the mitochondrial gene before we do it. But because it may be his only option, actually, to rebalance his system.
I disagree with you.
That's fine. I know it's not.
It's not simple. It's not the case. It's not a simple case. I don't know that me either. I will hesitate to put gentamicin. I rather eventually, if he is very, very impaired, and I rather perform an electrocochleography to see that there is some expression of a secondary hydrops. Why not? And maybe I will try before acetazolamide.
Oh yeah, I would agree. I would agree with acetazolamide, but I'm saying eventually.
Yeah, eventually. Okay, man.
It's not going to be first option. Yes.
Yeah, I would use that as a last resort, and
yes,
and
of
only
course.
if he was
Of
really
course.
miserable. Yeah.
And functionally, he's improving too.
Okay, it should take this as in the context, Amy. Thank you for your. He progressed. This is a very important thing.
Awesome.
So after you clean it out, you didn't put any fat, did you? Or you just leave it with a. You didn't pack that area with a fat like we do after acoustics.
No, I put the muscle plug in the vestibule to plug up the CSF leak, and I left everything else open.
Was it a strong leak or just a tiny little leak?
No, it was a strong leak. It filled up the mastoid real quick. Yeah.
So my worry is if it's still leaking from that area, if he's a big guy with active tiny little leaks in there. So okay.
I don't think so, because like I said, once I put the muscle plug in there, it stopped immediately. And I mean, it was literally like putting a cork in a bottle.
That's a rough spot too. That's the area you can't support it with anything too.
Yes, especially that on the CT, we saw that at the in the contact with the cochlear wall, there was a very thin bone structure, and maybe there is an internal fistula between the internal auditory canal and the remnant capsular OT capsule.
Yeah, I agree. Yeah.
Good job.
All right, guys. So next
Right.
next meeting we're scheduled for Friday, January 9th, and Mohamed's going to do a case of is it migraine or hydrops, and I'm curious to see what he comes up with here because that'll be a hot topic.
It's a very hard and tough
Well,
topic.
migraine is a diagnosis clinically. Hydrops is a diagnosis actually of autopsy. But I would I would like there is that paper that we've been talking about, seeing endolymphatic hydrop patterns with the MRI in patients with migraine, and that's a very interesting paper, and we'll talk more about how we make differential diagnosis and take it from there.
Awesome. All right, guys. Well, y'all have
Thank you all.
good month.
Thank
and
you
good
very much,
holidays.
Jerry. That really is a wonderful case and very educational case. But would like follow up on that.
Awesome. I'll give you some follow-up when we talk next month.
Yeah, sure.
Yes. And have a
If you
nice,
see that.
very, very good and nice excuse me, holidays for the Christmas.
Yeah, everybody, wonderful
to you.
holidays
Same to you.
for the Christmas,
See you
New Year,
guys.
until we see you all again.
Y'all take care.
See you guys.
Gerard, are you working on the project, on the paper?
I will be. I'm at the point where I'm just about caught up.
Okay, you stop because I want to send that thing out.
All right.
Okay, all right then. See you
Good to
later.
see you, Bullet.
Bye bye.
Bye-bye.